Hello and welcome to Inside Oncology, the podcast where we explore the science, progress, and human stories regarding shaping cancer care today. I'm Poovenraj Kanagaraj. In this episode, we are joined by two distinguished experts who are at the forefront of cancer management in Malaysia. Our first guest is Dr Hafizah Zaharah Ahmad, a consultant clinical oncologist with years of experience in tailoring cancer treatments to the needs of patients and advancing multidisciplinary cancer care. Also with us is Dr. Johann Faizal Khan, a consultant general, hepatobiliary, pancreatic, and liver cancer surgeon, whose work has been instrumental in improving surgical outcomes for complex liver and improving pancreatic cancers. Together, we will delve into the current treatment approaches, breakthroughs in oncology, and how collaboration across disciplines is shaping better outcomes for patients. Doctors, thank you for joining us today. So let's kick off the first question, and I want to talk about early detection, right? Whenever someone speaks of cancer, we always talk about early detection. We are always pushing for early detection. So Dr. Hafizah, maybe we can start off is, when we talk about early detection, what are the signs to actually first for us to actually familiarize with? How would someone know that they are having early signs of liver cancer or even symptoms?
I think for liver cancer, it can be quite difficult because majority of the patient at early stage is asymptomatic, meaning they do not have any symptom. Those who may have symptom is usually very vague symptom and may mimic like gastritis symptom, bloated, is really not specific. So patient may come because of, I have abdominal pain, abdominal distension, and after a while, then when they start losing weight, or they maybe family members commented on some changes, some physical changes, then only the patient will be alerted. Because they may just, even though they may present themselves to clinic, but without imaging, they may be treated as a simple gastritis or wind problem. So my recommendation is, if we have prolonged symptom like persistent abdominal pain, persistent abdominal discomfort, and something that is not quite right, I would recommend to see a specialist. Then only imaging will be done, either in the form of ultrasound or a scan and further blood tests. And if needed, cancer marker, then only we can actually diagnose if the patient have liver cancer or it's just a simple gastritis.
Let's say a patient comes in early. How does it influence your ability to treat them? At what stage do they come in, and how does it influence your ability to treat them?
When they come at the early stage, meaning early would mean resectable. It can be surgery. I think that would be an ideal situation, because the best outcome if when the liver cancer can be resected and they can immediately see and consult the Dr. Johann, hepatobiliary surgeon, and get it removed immediately.
So Dr. Johann, we were talking about surgical. When patients come in, and you were saying you would be the first layer when they come in, right? So how do you actually determine that surgery is something that's required at that stage, or would it be non-surgical?
Yeah, so I think it's very important to look at the patient as a whole. I think this day and age, we should be looking at practicing precision medicine. All our treatments, investigations and everything has to be tailored based on the patient's needs, requirements, the patient's physiological status and the underlying disease. I think when we talk about liver cancer, I echo what Dr. Hafizah has mentioned, that more often than not, when you do develop symptoms, you come at a later stage. We are not only dealing with the disease, the liver cancer itself, but we are also dealing with patients who more often than not have background liver disease. And that's where we talk about risk factors like chronic hepatitis B, hepatitis C, history of chronic alcohol abuse, and something that we should be very mindful about in society nowadays, which is MEFL, or metabolic associated fatty liver disease. So in summary, we base our treatment perhaps on the number of tumors, the location, the patient itself, what are the patient's physiological status, to what degree the patient can accept different forms of treatment, and also we manage in a multidisciplinary team approach. For instance, if a patient has got chronic hepatitis B, we need to suppress the viral load, we need to refer to a gastroenterologist and hepatologist, make sure that the patient is suitable to undergo different forms of treatment.
You mentioned risk factors, right? What kind of risk factors do you usually look at? Is age, does gender influence, or does age influence in terms of weight? Obviously, why I'm looking at is, we can't just look at cancer as just cancer, right? We look at NCDs and are they obese? Does all these other factors influence? And could you share some examples as well?
Yeah. So as I alluded previously, I think if you look 10, 15 years ago, that most patients with liver cancer were probably patients who have chronic hepatitis infection, especially in Southeast Asia, in Asia. We are a country which is endemic for hepatitis B. So we are now dealing with patients who have got long-term hepatitis B, for example, 10, 15 years, where the liver has become cirrhotic, and cirrhosis is a risk factor for cancer. But as I also mentioned previously, nowadays younger patients are getting liver cancer because of fatty liver. It is a risk factor. Patients who have fatty liver may also have other metabolic problems like hypertension, dyslipidemia, and also diabetes. So this younger age group of patients are possibly developing liver cancer even without the background of cirrhosis.
So, at one point, obviously, to the public, right, consumption of alcohol leads to liver cancer. That was the usual thought or the perception to it. But obviously, with KKM now announcing, more focus on liver cancer, they're also saying, there are so many other factors to this. Is it still the same case with liver being the major contributor, or do you think it's just a lifestyle issue that has actually influenced this risk in younger people as well?
No, I think alcohol is definitely a risk factor. Being of male gender as well, smoking, these are all factors that to a certain degree may confound the other risk factors that you have. I mean, even if you're going to treat a patient with liver cancer, all these factors have to be dealt with. We've got to ask our patients to stop smoking. We've got to ask them to stop drinking alcohol. They will influence outcome, prognosis, and also your treatment. So it's all these lifestyle changes have to be dealt with. And I think it's a society, it's something we need to enforce in the society, not only for liver cancer, but I suppose cancer as a whole and our general health as a whole.
So are patients willing to stop smoking and drinking? I think both of you could give an answer to that, right? Are patients willing to stop? Or is the hesitancy still at a very high pace? Obviously in NCSM we have a quit smoking clinic, and we, when I speak to the MOs there is still that friction. Okay? People will come, they will register, and then after 2 to 3 weeks they kind of drop out. Do you still see that in your cases, Dr. Hafizah? Maybe you.
Okay, I think majority lah. I would say majority, because when after the first diagnosis, I will sit down with the patient and family to make them understand the diagnosis and then lay out the plan of treatment. And I do need some cooperation as well in terms of I may offer all the treatment available, but I want also some dedication, cooperation with the patient and family in terms of the choice of food, choice of lifestyle, including cutting down on alcohol intake as well as smoking. So I would say that support from family is very important. So family that is supportive would have, I would say, can help patient to make the correct decision in order to make the correct choice of lifestyle. And if I may add, male make up, there's more 2 or 3 times more number of liver cancer compared to female. So that is another point to highlight.
Would you say it's because of lifestyle?
I would agree so, because of lifestyle.
I see. We obviously spoke about the surgical point of view, but what is the treatment journey like for non-surgical options? When patients come and see you, when Dr. Johann, refers you his cases, what can you run us through? What is those steps like?
So, okay, let's say this is an advanced case that is not suitable for surgery. And what I have to talk about is about option of treatment, and we know that chemotherapy is not suitable for liver cancer. That is actually for a fact. So the treatment for liver cancer is mainly targeted therapy plus or minus immunotherapy. So that would be in the guideline. In terms of the treatment, first it will depend on the stage. The stage, for example, whether it is at BCLC C, or for example, let's say it's already at advanced stage and not suitable for any treatment, then I would discuss about palliative care and supportive care. So now let's touch on a patient that is still amendable for treatment and clinically is fit. So the first line of the treatment would be targeted therapy or targeted therapy plus immunotherapy. Targeted therapy is actually in the form of tablet. So I think that also make the treatment easier because tablet patient can just take at home, but they do still need to come to the clinic, to my clinic, to monitor the blood tests as well as the side effect. But majority is tolerable. In terms of the immunotherapy, it is actually in the form of injection. So patient need to come to the daycare for the injection treatment every 3 weekly, but it is also well tolerable. So it's not like previous, before the advent or before the availability of targeted therapy and immunotherapy. Okay, this is when I was just a medical officer. At that time, targeted therapy is limited. There's no immunotherapy at all. At that time, we still actually offer chemotherapy for hepatocellular carcinoma.
Yep.
So that was like more than 20 years ago. But now with the availability of many advanced treatment, so I would tell patient, even though it's an advanced stage, potentially you can respond to it and have a better quality of life. So I would still push for treatment, especially for patient who is fit.
You mentioned fit. Does it come in what category does fit fall? In terms of, is it someone who works out all the time, or is it someone who's, you could be 56 and you still work out all the time? What does fit in the Malaysian context?
Okay, so fit in terms of treatment context, for example, let's say patient can still take care of themselves. Okay, I wouldn't expect them to be able to work as before, but at least be able to feed themselves, take care of themselves, independent, may require some form of assistance, is still considered as fit. So some patient is actually maybe using wheelchair because they might not be able to walk long distance, but despite that, their nutritional status is still acceptable. I would still consider to give treatment.
Okay. Dr. Johann, in terms of surgical point of view, right? Patients who come in, you mentioned they will come in to you first usually. You mentioned that there are sometimes resistance into abandoning that lifestyle that could have contributed. But in terms of surgery, the concept of surgery, and also a lot of Malaysians, they're sort of, is it really, should it be really a first option? What's that experience like working with patients who may not want surgery, and how do you convince them that surgery is the way to go? What's that experience like usually?
So I think almost all our treatment is based on current evidence. So I'll give a very simple scenario. If I have a patient who comes to see me, I will look at possibly 3 facets. One, like Dr. Hafizah mentioned, is the patient fit, whether the patient has any medical problems, for example. Then I'll look at the quality of the liver. Are there any contraindications to perform surgery? For example, if the tumor is small or the tumor is not too big, right? And the third thing will be offering different options, because sometimes management can be varied. For example, if a tumor is small, we don't have to surgically remove it. We can perform certain interventional radiological procedures like just burning the tumor, especially for tumors which are about 2 to 3 centimeter, right? And what we do nowadays is we do more minimally invasive as well. We have removed tumors from half the liver, with just using keyhole surgery, and our patients go back faster. So this is something that this day and age we can offer patients, which were probably not able to offer them maybe 5-10 years ago, right? And one more last thing is that even nowadays we can treat liver cancer with actually liver transplantation, where we remove the whole liver, you remove the tumor, you place another new liver, and the risk of developing new cancer is less.
Yep. What's the liver transplant landscape like in Malaysia? Oh, you've been doing this for quite some time. What's that like? How has it progressed? Because if I were to speak about liver transplant to people, they're all going to look at Grey's Anatomy and think, you're going to have to be on a waiting list and you have to wait for the liver to come in from another hospital. But what's that like in reality?
So in reality, it's a viable option. Of course, there are certain criteria that will qualify you or disqualify you from one. The good thing about liver transplant is that it offers an opportunity to remove the source, which is the risk, which is removing a cirrhotic liver, for example. I think there are centers in the country which do offer, and more patients are being worked up for liver transplant, especially with underlying hepatocellular carcinoma. The thing is, these patients, especially when the cancer is early, while removing the whole liver, transplanting them allows them to basically have like a new liver, a new lease of life. So this is an option, and I think there are centers in the country which do offer.
My next question is something I assume would be quite common from patients. That what's the risk, like to do surgery? Will it get worse, or will I die if I do surgery? What are the chances? I do not know if you get this question, but I definitely seen these questions come in, right? Oh, what are the risks usually from surgeries? Is it safer today than it was perhaps 10 years ago?
So I think part of the surgical journey is actually deciding first and foremost if this is the right option. Second, as a surgeon, I always offer patients options. It may not be the best option. So we look at all facets, all options. We give the patient different options. And I think it is important that there is no such thing as 50-50 risk, right? These are all calculated risks. The risk is based on the patient's performance status, how good the surgery, whether we are able to remove it successfully. So I always tell patients there is risk, but it's all calculated risk, and patients need to understand that more often than not, surgery aims to cure. So we have to look at the risks, benefits of it. Yeah, it's a difficult question to answer.
Yeah, but I obviously want to jump into the post-surgery lifestyle, right? But before we do that, I want to talk about multidisciplinary approach. For a patient who's coming in who may just have been diagnosed, what is the multidisciplinary approach to that treatment? For example, is there different approaches to different conditions or different stages of liver cancer? And who else is usually involved? Do you and Dr. Zaharah also work together? How often do you do that, and why is it important to have this multidisciplinary approach?
Yeah.
Okay, I think first, when there is two options of treatment. So for example, like just now Dr. Johann mentioned, surgery versus ablation. So that would involve surgeon and interventional radiologists. But it could be also ablation and targeted therapy. So that would involve me and interventional radiologists. So what I will do usually, I will just call up Dr. Johann and the interventional radiologist and just discuss regarding the patient condition as well as the imaging, and we line out what are the patient risk factors as well as patient's preference and see which would be the best option. It could be combination. It could be a combination of, let's do, this patient is suitable for to give a few cycle of targeted therapy, shrink down as much as possible, and then do the liver ablation. So it could be combination approach. So discussion. So we always actually just pick up the phone, call each other, and just discuss. In some occasion, we actually see patient together and to discuss the risk and benefit before making the decision of treatment. Yeah.
Yeah, so I think it involves different disciplines, clinical as well as non-clinical, like what Dr. Hafizah has mentioned. Um, we always, in a multidisciplinary approach, we always try to fit what is the best based on a discussion. And we find that once we get a final decision, we actually inform our patients. I think a lot of times we always look at there's no one size fits all. So everything has to be tailored based on the patient and based on the tumor biology and so on. So those are things that we, yeah.
I see. So now speaking of post-treatment lifestyle, let's say from a post-surgical point of view and a post-non-surgical point of view, what is the lifestyle usually recommended after that? Do you see patients, who could have abandoned their vices, for example, during treatment period? I stopped smoking, I stopped drinking, but of course these temptations come. Even I've seen it with patients who have had heart problem. They'll always go and ask, how much of alcohol can I drink, doctor? Right? What are the usual common questions that you get when a patient has completed the treatment after surgery, for example, Dr. Johann?
So the common question I always get asked is if this is his final treatment, and which comes to an important aspect of cancer management, which is surveillance. So after any form of treatment, patients go into an intense surveillance kind of like protocol. So we always make sure that that patients get scanned, there are blood tests to be taken, there is a scheduled follow-up. So, and during this point of time is the time where we reinforce to patients that risk of recurrence is always there. So managing your lifestyle is actually one of the best things you can actually give to yourself to prevent recurrence.
Would you advise that it's better to stop drinking completely than to even have moderate drinking lifestyle?
Yes, I think an all or none law is always the best best approach. Yeah.
What about your side, Dr. Hafizah? What are the common questions that you've gotten that could be different than that?
Okay, so usually in terms of treatment for targeted therapy or immunotherapy, potentially it is a long-term treatment because my patient would be in the category of advanced liver cancer, non-resectable. So the treatment that I'm talking about is long-term. Long-term meaning as long as the treatment gives benefit. So as long as patient condition is stable, the tumor is under control, we will continue the medication or the tablet. So while continuing the treatment, in terms of the maintaining healthy lifestyle, maintaining a well-balanced diet would be very important. And I usually get the dietitian involved as well. Because from my side, actually, patient may have problem to maintain the nutrition. They may have loss of weight, either due to the disease itself or to the side effect of the treatment. So in terms of that, I do need to make sure that the protein intake is good, the carbohydrate intake is good. So we want to maintain the nutrition as well as the body weight as balanced as possible throughout their journey, and I think dietitian would help that as well.
I see. And speaking of diet, right? We live in Malaysia, so that's obviously a challenge in itself, really, right? You can wake up in the morning and say nasi lemak, and this is something that we have grown up. Imagine could be 40 years of habit, and then if you're diagnosed at the age of 45, that's letting go 35 years of habit down, right? Someone could ask, do I stop everything completely? Do I just go organic? Do I just go brown rice? What do you have to say for that, Dr. Hafiz?
Okay, first, you don't need to just eat brown rice. You can eat white rice. Actually, you can eat white rice or you can combine. The key point is the amount. So the amount of rice must be balanced in terms of our age and body weight. Okay, and then the protein intake. We do need a balanced protein intake. I do have a patient asking me, doctor, can I switch to keto diet? Then I say, it's not suitable to just take protein. You do need carbohydrate because once you stop the carbohydrate completely, you start losing weight. So, and I don't want that to happen. So if you want to cut down, yes, but not like completely stop the rice or the noodle. So You can choose instead of taking certain type of noodle, you might want to take pasta, and then in between alternate with rice. Another thing is actually fibers. That one is also very important. Certain supplement given by the dietitian is beneficial to maintain the protein intake. And yeah, another famous question, can I take sugar? Okay, so I will tell them, if you cut down sugar completely, and we don't do any cancer treatment, the cancers will still grow. So it doesn't need sugar to grow. It can go, but the cancer can grow by itself because they can actually derive the blood vessel or the nutrition from our body. So we do need to take sugar in the form of complex sugar, I mean the healthy sugar. So not to say cannot take sugar at all. So it is in moderation.
What is healthy sugar?
People say when you eat rice, it will turn to sugar. So, but you need rice. In terms of the what we should avoid is, for example, let's say a sugar glazed donut. I would think drink and with the whipped cream, that one is too sweet. That one is too sweet.
Anything
3 in 1.
Good,
Yeah.
Anything that's good, you should
Yeah,
avoid.
3 in 1 drink.
Anything that tastes good, basically.
Yeah, that one is can contain a lot.
Yeah.
Yeah, not with the whipped cream. Not with that one. I think it's too much. I think just one small 1 teaspoon of sugar in a cup of drink, that one should be enough.
Yeah, I would like to add a few things as well. I think, the other thing that I do get a lot is we talk about supplements.
Yeah.
So I think a lot of patients would think that, okay, we need to buy this supplement, this is good, it comes out on TikTok or Shopee. I think we need to be mindful about the content. And also when we have a liver disease, we are not sure whether our liver is able to metabolize all this. So it's very important, I think, to be very mindful what you buy, where you buy, and always seek a medical professional's opinion on whether this is something you can take.
Yeah. It's interesting that you brought up supplements, right? Because once again, being Asian, we don't just look at supplements, we look at traditional medicine as well. Would you, and we still do have group of the parts of the society, they're like, before I go and say, doctor, I'm going to take, for example, jamu dulu. Okay, I'm going to take something traditional. And it's actually there in every culture, in every race. We all have, culture brings in a lot of the, the traditional medication, traditional concoction, right? If you're already diagnosed, would you still advise someone to continue traditional concoction, for example? Or would you say, stay away from it and stick to medicine first?
I think historically, all forms of medicine are based on traditional ingredients. But I suppose where the problem lies, with the devil in it, is probably the fact that there are a lot of these there are a lot of supplements or traditional medicine which are probably packaged with other substances, for example, steroids or other concoctions that may not be suitable for normal daily use. So that is where I think the problem would probably lie. Yeah. So my advice is to seek medical attention first and have a discussion with your physician and see whether this is something suitable, advisable for you. Yeah.
I actually offer supplement that can be taken during cancer treatment. So that is scientifically proven. And then as well as I said, you can make your own supplement in the form of, you can combine a few types of fruits and you can blend it and then you can just drink it. That would ensure there's no sugar or chemical. So that is actually a natural supplement. So I would actually recommend patients, you can start with this first. Very simple step, but it's beneficial because it has a lot of vitamins.
Because, there's another conversation of physical activities. Obviously, exercise, Malaysia is one of the most obese countries in Southeast Asia as well. And of course, after treatment, we are sort of like, okay, I'm going to start running tomorrow. I'm going to buy my running shoes. I'm going to go start walking. How much of physical activities can they take after surgery, or even while they are going targeted therapies? What's that like for them? Would you advise them to go on or take it slow, or can they resume? If someone's, for example, obviously you have all this strength training that's going on happening now. What's that like usually? Can they go back, resume physical activities? At what level or what stage should they take it on as well?
So the aim of treatment is always to have someone go back to your natural, pre-treatment stage. It will take time, definitely, and that's where we work with our physiotherapists as well. In terms of post-surgery, we try to get them back to their normal daily activities. But at the end of the day, I think all forms of treatment is to bring someone back to their normal activity, and they will definitely be able to resume their activities. But I'm not sure when patients with advanced cancer. Dr. Hafizah, what do you think?
Okay, so for most of my patients, usually because of the tiredness, they may need some help from their family members in the form of helping them or accompanying them to go to a simple walk around the neighborhood. So I usually tell them, when you are feeling up to it, you may want to just take a walk for 15 minutes, accompanied by someone. Okay, and then after you feel that, you're feeling stronger and stronger, you can take it further, like 30 minutes per day as a start. So because we do want to improve the physical activity, and light exercise actually improve the patient's tiredness, actually. So they can also do a simple stretching. You can also find a short video exercise for cancer patient, because you can even do exercise on the chair. So it's the same. You can start patient on the chair and do the stretching or exercise, and after that, if you feel up to it, you can start walking about around the neighborhood.
Okay, interesting. Now we are entering the last leg of our conversation, right? And I think this one actually goes back to our very first conversation, and also what we do on a yearly basis in terms of screening, detection. We could have the everyday healthy person who wants to come in and say, I may not have the signs, but I'm doing my health screening every year. Is there tumor markers or cancer markers for liver cancer specifically that I can include in? Should I include it in as well when I do my yearly or annual cancer screening or health screening?
So I think it's very important to understand that liver cancer is not like breast or colorectal cancer, where we have a national screening program. Patients with liver cancer, we screen patients who are at risk. For example, family history, background of cirrhosis. So, and that's where I feel the problem also lies. And so what we're doing sometimes, a health screening and all, is probably the least probably the bare minimum that we can do. And I think tumor markers, for example, alpha fetoprotein, right, and also ultrasound. And ultrasound is basically a very simple tool which is not invasive, helps to detect liver lesions at the early stage, and that's something we can do. And also when we start to when we have a background of certain risk, for example, smoking, we are diabetic, we are prone to any form of cancer. So putting that little bit of effort in your health screening, I think, will come a long way in helping detect not only liver cancer but other forms of cancer.
I see. So doctor, staying on the topic of screening, right? How do we actually raise awareness, especially for family history? Are people aware that if I have a family history, I need to go and do my screening, or do you think that awareness there is still at a lower stage right now? What's happening in that area? Do you think people are aware that if you have family history, I mean, I would say if you already have family history, you should go and get it tested. But are people aware?
I think the awareness is still low. Sometimes they are aware, but they are afraid actually to do the screening. Actually, they are afraid to do the screening. So, but it is a real problem. So in terms of, so let's say for colorectal cancer. So the form of screening is actually colonoscopy. But not many people would agree to that. So that's why in the guideline, the simplest method is FOBT, meaning we check for fecal occult blood. So let's do fecal occult blood first, and if it is positive, then this particular patient, we straight away refer to the gastroenterologist or colorectal surgeon for colonoscopy. So I would think that a simple method would be important. Same like liver cancer, ultrasound of the liver every 6 months for at-risk patient. So patient who have hepatitis, chronic hepatitis infection, liver cirrhosis, at least should do ultrasound on the liver every 6 months plus cancer marker alpha-fetoprotein.
I see. How often, you mentioned ultrasound, but in terms of screening, should they do it once a year or twice a year?
Yeah, so I think so there's a difference between screening and surveillance. I think surveillance is mostly when you have a cancer, you want to detect recurrence. But when it comes to screening, like at-risk patients that we talk about, the recommended guidelines is an ultrasound every 6 months to a year, and alpha-fetoprotein every 6 months as well. Every 6 months as well. Yeah, but I gather sometimes for patients who do not have risk, they're not at risk, I suppose having a yearly ultrasound as also part of your health screening, where you can actually detect precursor lesions or even fatty liver, would be something that is, I would say, pragmatic.
Okay. I suppose we are towards the end of our conversation. What's one message would you have for audiences, especially young audiences? Maybe Dr. Johann, you can kick off first. What's one message would you have to share to people today?
I think it's the most important thing is probably to be mindful of your health. And I think at this day and age, with the advance of imaging and treatment, and so much information about living healthily, I think we need to take charge of our health, right? And that's one message I would, give to the young audience out there. Yeah.
Dr. Hafizah?
I think the diagnosis of cancer is not necessarily the end. It's not necessarily the death sentence. There are actually effective and more advanced treatment available. So talk to your doctor, talk to your oncologist, be open to the treatment, because potentially the treatment can be life-saving and even can provide better or improve quality of life.
I see. Well, thank you, Dr. Hafizah, and thank you, Dr. Johann, for sharing your expertise and your insights with us. I'm sure there's a lot more we can cover, but there's more time for that as well. And to our listeners, thank you for tuning in to Inside Oncology. Until next time, I'm Poovenraj Kanagaraj. Stay informed, stay inspired, and take care.